So you want me to start?
No, sir. No, sir. One second. Hello.
Hello. A very good evening to all the faculties and delegates. I welcome you all to the virtual webinar on Hematology Masterclass, Selected Updates from ASH. I would like to thank each one of you for registering to the webinar. And let us start with our agenda. So I would like to invite our organizing chairman, Dr. Ashok Vaid sir, who is the chairman in the Department of Medical Oncology and Hematology from Medanta, to deliver the welcome address. Over to you, sir.
Thank you, Anshika. And at the very outset, I have to thank Om Mishra for the series of webinars we have organized in the year 2023 as we look back. And we continue to have his support, hopefully in the year 2024 as well. And I thank him personally and his companies, Summers Life Sciences Private Limited. I have to thank Rajesh, Priyanshi, and their team for the wonderful job for popularizing all these programs. And today we have more than 150 registrations already. Friends, it is often said, or rather it was often said, that human research is a very slow, painful process. And the practice-changing drugs and combinations would take a long time in the yesteryears to come to the bedside. Having gone through those didactic and the rigmarole of preclinical to phase 3 trials, and even at the end of the phase 3 trials, sometimes we would find that it's a futile therapy. And this was a mandatory way the drugs were developed in the past. However, and thankfully, the paradigm has changed and has been moving target over the last about 2 decades, ever since the targeted approach in oncology stepped in and the drug development cycle of 10 to 20 years has been shortened. Though we know that there are still many gap areas, unmet medical needs, and drugs need to come into those therapeutic areas very quickly. And Dr. Pendarkar is going to teach us about the sickle cell, which is again one of the unmet medical needs. And we today do not, generally would get into futile therapies by the downregulation of the many pathways. We can select and deselect drugs very early on. And of course, today we would be discussing certain issues, and 2 of them, which probably, sickle cell is very less often talked about. We don't call it as a India-specific disease, but it indeed is. And today the number of sicklers in India is mind-boggling. It's close to about 5 crores. It's a disease of the central India and of the tribal belt. The gene which mutated went to the Middle East and from Africa and came to India as well. And astounding numbers in Africa, Nigeria, Zimbabwe, and Uganda, up to about 30% of the population could be sicklers. And it's still an unmet medical need. And besides that, we have chosen topics which are interesting from the practice and from gaining knowledge. Oral arsenic trioxide, it's an Indian story again. So these 2 topics are very, very India specific. And of course, there are very interesting lectures on mantle cell. We have moved away from chemotherapy in CLL. We would continue to look at CLL. And of course, there would be a day when we are also looking at no chemotherapy regimen in mantle cell as well. Smoldering myeloma continues to be a challenge, and we have some good news, and we would be listening to that as well. And APML, of course, the arsenic trioxide story we would be looking at. So friends, with that, I would pass it back to Anshika to take the proceedings further. And we do hope that the evening is the next 1.5 hours. Of course, after the lectures, we have the panel discussion as well. And all this enriches our knowledge, makes us more knowledgeable about our practice and our day-to-day, the difficulties we come about. Thank you so much once again. Back to Anshika.
Thank you so much, sir, for such a warm welcome. Now, moving forward, I would like to invite our first speaker, Dr. Dinesh Pendarkar. He is the director in the Department of Medical Oncology, Cancer Care, Hematology, and Bone Marrow Transplant, Sarvodaya Healthcare in Faridabad. He is going to speak on long-term analysis of dose optimized hydroxyurea from treatment of pediatric patients with sickle cell anemia in sub-Saharan Africa. Over to you, sir.
Oh, good evening, everybody. And I just want to first share my screen. Hopefully, can you see the screen? Hello?
Not yet, sir.
Can you see the screen now?
Yeah, now we can see. If you could bring it to a slide.
Yes. So, is
Thank
it
you,
okay
sir.
now?
Thank you, sir. Very well. Thank you.
Fine. So, the topic given to me today was the long-term analysis of a REACH trial, which was presented. This is actually a trial which was already published 2 years back in New England Journal of Medicine. The trial is about the use of hydroxyurea. We should know that sickle cell disease is phenomenally common disease in India. There is no exact number known. The government data does not exactly tell the numbers. But if you take the data from the areas where the research is happening, the sickle gene positivity is something in places up to 40% in some parts of Odisha. But if we talk of sickle cell disease or sickle cell anemia or hemoglobin SS, it is sometimes up to 2% population. So there are districts where there are 1,000 patients registered in one district. We know that it's an inherited hematological disorder. We know that this is an important disease. And it's really important for all of us because we see it. Ultimately, patient comes to us for transplant. The only drug which is actually making a difference in the life of sickle patient today, if I don't do a transplant, is hydroxyurea. There are 3 or 4 more other drugs like crizanlizumab, voxelotor. Unfortunately, they are not available in the country and they are not used. So this trial was actually designed in Africa, a phase 1-2 trial of usage of hydroxyurea, and the whole idea was whether you can use in places like Africa and how long can you use and what should happen. So this was the trial design. Initially, for 6 months, hydroxyurea was given at a fixed dose of 15 to 20 milligram per kg per day. And once the dose was stabilized, it was increased to 5 mg kg per day. A very interesting fact was how to increase the hydroxyurea dose. What they did is they tried to control it along with, like we know, hydroxyurea we've been using long back for chronic myeloid leukemia. It brings the counts down. So the way of calculation of the dosage was give dose so much that ANC does not follow actually below 3000 and keep increasing the dose up to 35 milligram per kg body weight. And the primary safety endpoint was that the dose was the dose limiting toxicity, but the actual trial of the was that it was a feasibility trial. So they wanted to see how much patients are enrolled, whether we can retain the patient on a dose, whether it is safe to give long-term hydroxyurea, and what are the benefits, especially benefits as far as related to sickle cell events. And the sickle events we know are mainly two major events which we are bothered. One is a VOC, veno-occlusive crisis, and second is a transfusion requirement. These are two important events which are recordable. So this was the trial design of this study. 606 patients were actually enrolled on day one, out of which 44 died during the treatment and 40 exited treatment for various reasons. So ultimately, 522 patients remained in the study. They were all age group, starting from year 1 to year 12 actually. The age was 5.4 years. The mean hemoglobin was 7.3 and the HbF percentage was 11%. I have been given 10 minutes. I will be taking extra 3 minutes to tell actually the Indian data. So when this hydroxyurea was used at this dose with this strategy, when during the first 6 months, when it was a fixed dose used, 15 to 20 milligram per kg body weight, the amount of vaso-occlusive crisis was 72.7, which reduced to 43.6% with a p-value of less than 0.005. Similarly, the amount of acute chest pain, primary stroke, secondary stroke, malaria, and other infections also reduced. So, as we know that in sickle cell crisis, the primary problem for which a patient comes to us is a VOC, vaso-occlusive crisis or pain crisis. So definitely hydroxyurea helped us in bringing out that. The acute chest syndrome was another second complication, which also came down with an increased dose of hydroxyurea. As far as serious adverse events were concerned, the drug was absolutely tolerable. And hemoglobin values increased from baseline in all the patients. So dose escalation was possible in practically all the patients, and dose maintenance was possible. The hemoglobin levels were maintained. The absolute neutrophil count was also they were able to maintain with normal standard dosage of hydroxyurea going up to 35 milligram per kg body weight. So what happened in this study? In this long-term analysis of ongoing phase 1-2 REACH trial, it was proven that hydroxyurea treatment is tolerable. It is effective as far as sickle cell disease is concerned. It improved clinical outcomes and it often sustained benefits in lab values. Dose optimization. So they started with a small dose, increased to a higher dose, was not associated with lab toxicities. It was possible to increase the dose without compromising. So much so that when the trial was initially started, it was mandatory to do CBCs very frequently, literally 2 weeks to 4 weeks. And if we see this statement now, ultimately they decided that even if you do CBC annually 2 to 3 times, it is enough. Very important statement for tribal areas of India. You don't have to, you don't have to chase the patient, and patient does not have to report to the hospital. So investigators concluded that phase 1 and 2 REACH trial data support use of hydroxyurea at an optimal dosing into sickle cell programs in sub-Saharan Africa. So this was a data from establishing the role of hydroxyurea in Africa. Now, I will come down. I've got few minutes left and I will come down to Indian data. Why I will come down to Indian data, I will tell you. So in 2023, I have published 4 papers on sickle cell disease and 2 abstracts on sickle cell disease. This is all in 1 year, 2023. This is one of our papers on stem cell transplants. I had reviewed about 174 patients, which I saw in Burundi on sickle cell disease. This is one of my recent publications last week. This paper, which shows real-world HbF status, it is actually a status on the usage of hydroxyurea in Indian population. So what is happening in Indian population? The dose used in Indian population is even smaller, which was started by Odisha team, which is taken over by everybody else. It's just 10 milligram per kg body weight to 15 milligram per kg body weight, fixed dose. Because in India, we got only one dose available called 500 milligram capsule. There is nothing else available. So you have to either use one capsule for a patient or take the powder out and make few, one half here, one half there, no fixed dose. So generally a fixed dose of hydroxyurea is used. None of the patient is receiving beyond 25 milligram in any patients I reviewed. I've reviewed few thousand patients in last 1 year. So our dose is much less. Our problems are much less. We are not like African patients, and a smaller dose also works in India. So this was one of our third papers. My another paper, again, we did an analysis of a large number of patients from one of the districts, and that was also reported. And in this ASH, in this year, we had two published abstracts. One was, what is the eligibility amount of people requiring transplant in Indian population. That was one of the papers. And what is the level of healthcare workers of knowledge in India about sickle cell disease? Can we, as you know, government has a program of eliminating sickle cell disease. Can we actually target this program of elimination of sickle cell disease? Are our health workers ready to do this? So we did another study of knowledge of healthcare workers. So we have really spent a lot of time this whole year on working on sickle cell disease. Hydroxyurea is an excellent modification, excellent treatment, freely available in all government hospitals of India. So practically, the usage of hydroxyurea is very good in few states, and in other states where it was not good, is being taken up very seriously because of the government programs. So hydroxyurea, preferably all of us should now know how to use hydroxyurea. It should be mandate on the part of medical oncologists to teach the community physicians how to use hydroxyurea. No better than us can teach them, because we really know how to use hydroxyurea well. There is no need to be afraid of toxicity. And the abstract we discussed today from ASH, the REACH trial, it again shows the level of toxicity is practically nil, and we can go to high level of 30 to 35 milligram per kg hydroxyurea if the lower dosage is not being used. Thank you very much.
Thank you so much, sir, for such an informative talk. Now, moving ahead, I would like to invite our next speaker, Dr. Arshad Raja. He's an associate consultant in the Department of Medical Oncology at Kaveri Hospital, Chennai. He's going to speak on all organs arsenic trioxide-based induction in newly diagnosed acute promyelocytic leukemia. Over to you, sir.
Can you share my screen? Huh?
Yes.
I'm not able to share. Yeah. You're able to see?
Yes, sir.
So this is an all-oral arsenic trioxide-based induction regimen in newly diagnosed acute promyelocytic leukemia. Paper was published in ASH 2023. Similar paper was published in the EHA hybrid conference of 2023 also, where they had proposed this idea of all-oral arsenic trioxide-based regimen. This is a AAA regimen, that is ATO, ATRA, as well as ascorbic acid, which is used in a combination in induction, consolidation, as well as maintenance of APML. So this oral AAA regimen was proven to be effective in relapsed acute promyelocytic leukemia, yielding very high rates of durable remission. This was because of the bioavailability of oral medicine was almost comparable to that of the intravenous ATO. So the dose used in this study population was also almost the same which we use in our IV formulation, that is a 10 mg. So induction with all oral AAA regimen along with the chemotherapy improved the survival outcomes in patients with newly diagnosed acute promyelocytic leukemia. So this study presents the efficacy, safety, and molecular responses of the AAA regimen using risk-adapted strategy to minimize chemotherapy exposure. So this was a study design. So patients were categorized into standard risk as well as high risk based on the WBC count. That is WBC count more than 10,000 and age less than 65 years with no comorbidities. They came under standard risk, and patients with the WBC count less than 10,000 and age more than 65 years was classified as high risk population. So induction was almost the same which we use in most of the protocol, almost 6 weeks of ATO atra along with the combination of ascorbic acid, ATO at 10 milligram and ascorbic acid at a dose of 1 gram per day along with atra that is 45 milligram per meter square per day in 2 divided doses. So in consolidation, they gave AAA regimen for 14 days, almost for 2 cycles, and followed by a maintenance, which was a 14-day cycle in every 2 months. So if the patient was a high-risk candidate, then they gave daunorubicin for almost 3 days at a dose of 50 milligram per meter square per day. The primary endpoint here was overall survival, relapse-free survival, as well as the toxicity. The secondary endpoint was the molecular response in the bone marrow sample post-induction, as well as on peripheral blood after each consolidation cycle, and as well as during each maintenance cycle. So this was the overall number of patients was around 125, equal number of male and female populations. The classical variant was the most common APML variety. The PML rara isoforms, all 3 isoforms were seen, most common being the BCR1. CNS involvement was seen in almost 9 patients. So based on their presentation, they were categorized into standard as well as high risk. The standard risk was almost 75%, whereas the high risk population was around 25%. These are the median hematological parameters. We see hemoglobin, WBC, and platelet counts, along with PT, ABTT, and fibrinogen. So differentiation syndrome occurred in almost 76 patients out of the 125 number of patients, and yearly death was reported in around 8 patients. So this all oral arsenic trioxide based induction, when we see the efficacy outcomes, so almost all the patients achieved complete remission. 63 out of the 117 patients completed 2 years of maintenance at the time of this data presentation. The median follow-up was around 31 months, and the survival outcome was they proved a 3-year overall survival of 97% with a 3-year relapse-free survival of almost the same 97%. Only one relapse occurred during the maintenance period. So apart from that, another death occurred in CR1, which was due to gastrointestinal bleeding, which was unrelated to the current treatment. So the most common side effect profile was the headache, hepatotoxicity, that is a transaminitis, and along with nausea and vomiting. So this was more common with the oral ATO formulation. No treatment-related discontinuation was seen in the current study, and the differentiation syndrome occurred in almost 68 patients, that is almost 55%, and almost all recovered with the dexamethasone. So based on this, they concluded that the ATO, atra, as well as ascorbic acid, all oral combination was highly effective in patients with the newly diagnosed promyelocytic leukemia. The 3-year overall survival and 3-year relapse-free survival was almost 97%. It was efficacious along all patient risk group and across all ages. The regimen was well tolerated, the most common side effects being headache and hepatotoxicity, along with the nausea, vomiting, and differentiation syndrome was very well controlled with the use of steroids. So currently, recruitment is ongoing in Asia for the frontline use of all oral AAA regimen for patients with APL. Yeah, thank you.
Thank you so much, sir, for such an informative talk. Now, moving ahead to the next talk, I would like to invite our speaker, Dr. Nitin Sood. He is a director in the Department of Medical Oncology and Bone Marrow Transplant at Medanta, the Medicity, Delhi. He's going to speak on novel strategies for treating double refractory CLL. Over to you, Dr. Sir.
Thank you, Anshika, and thank you, Dr. Ved, for inviting me to do this talk. I'm hoping everybody can hear me and in a minute can see my slides as well.
Yes, sir.
So Can you just confirm if you can see the slides and it's in presentation mode?
Yes, sir. It is visible.
Okay, thank you very much. So I was just hoping to to see if we can understand the considerations in selecting therapy for previously treated CLL. As we all know, CLL is a disease which is chronic and which causes accumulation of mature B cell lymphocytes. And because as CLL progresses and more mutations develop and the natural course of the disease is that it becomes more resistant to therapy. It's important that we have more drugs and more therapeutic armamentarium available with differing mechanism of actions, and we are lucky to have a variety of such drugs. So, I mean, it's also important for us to understand how to use these drugs and when to use which ones. So there were a lot of updates this year, and there is a lot of evidence which I'm hoping to present. Some of it is rehashing the old stuff, but there is a lot of stuff going on with BCL2 inhibitors, with MRD analysis in CLL. And that's what I'm hoping to give you an overview of how to choose treatment for your CLL patients when they relapse. So initially we used to do chemoimmunotherapy, and all of us remember FCR and BR. But now, for the last 5 to 10 years, they've literally been overshadowed by BCL2 inhibitors and BTK inhibitors. The things that are coming are venetoclax, the fixed dose combinations of venetoclax with anti-CD20 bodies, whether it's obinutuzumab or rituximab, how long to give it, whether venetoclax will work after it's worked for a fixed dose combination, and there's some evidence on that. And whether BTK inhibitor should be given continuously, what to do if patients decide to discontinue or have side effects on BTK inhibitors, or what to do if they progress on BTK inhibitors. So this is just a summary slide and probably the most important one to see how we choose therapy or how we decide therapy based on how our CLLs are behaving. So once the CLL relapses, it's a bit like the first diagnosis to see if treatment is indicated. First of all, we need to make sure it's relapsed and it's not progressed, or progressed meaning transformed, and whether there is an indication to treat. If there's no indication to treat, there are no B symptoms, there's no marrow failure, then like an early CLL or a new diagnosis CLL, we decide to observe, or if they're on therapy, then we decide to continue therapy. But if there is an indication to treat, and they've had prior chemoimmunotherapy, which a lot of patients of ours would have had, then the options are using venetoclax, rituximab, or obinutuzumab combination. So when R or when O in a fixed dose combination, or using a BTK inhibitor. Now, ibrutinib and acalabrutinib are the ones that we have access to, and I'll show you some evidence on zanubrutinib as well, because that's also an important drug. What if they've already been on a BTK inhibitor? Now, if they've already been on ibrutinib or acalabrutinib, which most of our patients will be now, we can still use venetoclax, rituximab, or obinutuzumab combination in a fixed dose or a fixed duration combination, or we can use venetoclax on its own as a continuous therapy. So venetoclax, although is not available in this country at the moment, but it can be imported easily, and it's available on the gray market. And most of us tend to use it for AML very much, not for CLL so much, but we have used it in the recent past for patients who've had prior BTK inhibitor therapy. If they're intolerant to one of the BTK inhibitors, and the reason for discontinuation is intolerance or side effects, then the obvious choice is to change the BTK inhibitor. And if they've had a prior BCL2 inhibitor, meaning either had venetoclax, one of the options is to retreat with venetoclax, and I'll show you some evidence on that. The other option is, if they haven't had a BTK inhibitor, then shift them onto acalabrutinib or zanubrutinib. So most of us would remember the Elevate RR trial, which looked at previously treated CLLs and stratified them on high-risk features, no cardiovascular disease, and no prior BTK inhibitors or BCL2 inhibitors, and treated them, randomized them into 1-to-1 ratio between acalabrutinib in the standard dose and ibrutinib in the standard dose. So the study was really it was a non-inferiority trial, and it was randomized, open label, and wanting to look at if acalabrutinib is non-inferior to ibrutinib. The primary endpoint was a non-inferiority, and there were a set of hierarchical secondary endpoints, AF being the first one, grade 3 or more infection, Richter transformation, or overall survival. But the study stopped at grade 3 or more infections because that was when the hierarchy was stopped. So the non-inferiority criteria was met, and you can see both the lines literally overlapping of acalabrutinib versus ibrutinib, and this was assessed by an independent review committee. The important thing about the trial was that acalabrutinib, which is the blue line on the two graphs, has fewer side effects, which means less atrial fibrillation, less bleeding, bruising, and less hypertension. The incidence of all these side effects continues to go up as you remain on the drug. So it's important that we understand that we continue to monitor for hypertension and atrial fibrillation as patients continue to take the drug. And because it's a indefinite drug, it's also important that we don't forget these side effects. So the other non-inferiority trial again was Alpine, which looked at zanubrutinib versus ibrutinib. So similarly, relapsed refractory CLL patients who've had at least one prior systemic therapy, measurable disease, no prior BTK inhibitors because both of them were BTK inhibitors, 1-to-1 randomization between zanubrutinib and ibrutinib until progressive disease or unacceptable toxicity, almost a 2.5-year follow-up, and the primary endpoint was non-inferiority. So the trial demonstrated that there was a progression-free survival superiority with zanubrutinib at the 24-month point, and you can see the zanubrutinib is giving us almost a 78.4-month progression-free survival versus 65 on ibrutinib. So again, ibrutinib or zanubrutinib was better in terms of atrial fibrillation, but because it's a less selective or it's a medium selective BTK inhibitor with some off-target effects, it does equally well or equally worse on hypertension. So this is just to show you how BTK inhibitors work, and if there are off-target effects, then there will be side effects. So acalabrutinib being the more specific, the little red dots show that they're just doing the target effects and not the off-target effects. Ibrutinib is all over the place. Zanubrutinib is somewhere in between. So in terms of side effects, ibrutinib is probably the most side effect causing first-generation drug. The next question that comes to our mind is whether retreatment with venetoclax following a time-limited venetoclax-based regimen will work. And this was a multi-center retrospective study, about 46 patients of CLL who've had 2 median prior therapies. And venetoclax-based regimen was, so when 1 is the group who've had venetoclax in the first time, and when 2 is when you retreat with venetoclax after a minimum gap of about 12 months or so. So you can see, you can expect if you do when 1, the CR in the blue in the pie chart, you can see CR and PR, meaning the overall response rate is almost 96%. But if you use venetoclax in the second time, meaning you've given a little gap and then used venetoclax and the patient has progressed, then you can expect an overall response rate, still expect an overall response rate of about 80%, which isn't bad at all. And on the right, you can see when to progression-free survival. So giving you a median progression-free survival of about 25 months. Again, not a bad thing to have. So a great drug to have in your armamentarium. So, what about whether venetoclax rituximab combination can induce long-term remission durations? And Murano trial looked at that. It was done a while ago. So Murano compared venetoclax rituximab combination with what used to be standard of care at that time, which is bendamustine rituximab combination, and they looked at relapsed refractory CLLs who had at least 1 to 3 lines of prior therapies, at least one chemoimmunotherapy containing regimen, and they randomized almost 400 patients between when R and BR. And we can see progression-free survival curves for both the regimens are vastly different. Murano also taught us that the value of MRD in CLL, and we can see that the green, the blue, and the orange bars. The orange bar is when the patient is MRD positive at end of treatment, and the line quickly drops, and we get a median progression-free survival of less than 6 months. So MRD, so Murano taught us that MRD was an important endpoint for treatment. And fortunately, venetoclax is the only drug that gives us MRD negativity. Even BTK inhibitors will not give us MRD negative. So is it still effective after ibrutinib discontinuation? And this open label phase 2 study looked at that. So they looked at relapsed refractory CLL patients who've had previous BTK inhibitor therapy. They looked at almost 91 of them. And they saw that this venetoclax, even after BTK inhibitor therapy, because it's a different mechanism of action drug, was giving us very high overall response rates of almost 65% with a progression-free survival of more than 2 years. And more importantly, it was giving us MRD negative disease even after, because this would have been like third line of therapy. To have almost MRD negativity in about half of the patients is not a bad drug to have. On the right, again, showing why MRD is important. So the orange line showing us that if you are MRD negative at end of treatment, median progression-free survivals not reached, as opposed to almost 2 years if you are MRD positive at end of treatment. So this is what NCCN now suggests. This is what the earlier graph was. If you have second or third line of therapy, your preferred regimens are acalabrutinib, venetoclax rituximab combination, or zanubrutinib. And ibrutinib still remains category 1, but because of side effects, it's moved on to other recommended regimens. What if you have 17P or TP53? Venetoclax still a great drug. Ven-R combination, acalabrutinib, zanubrutinib, all category 1. With ibrutinib again pushed to category 2. So literally very few differences between whether you have high-risk disease or not. These are the selected key abstracts from ASH this time, and I'd encourage you to look them up. But I'm not going to go into the details of these. So to summarize the talk, therapy for relapsed CLL is rapidly changing, and patients with relapsed disease have numerous therapeutic options. Even in our country, we have access to acalabrutinib, ibrutinib, which are both generic. We have generic venetoclax, rituximab, obinutuzumab, and literally there is no role for chemoimmunotherapy in the relapse setting now. And therapy of relapse CLL heavily depends on what was chosen as frontline treatment. So if you have chemoimmunotherapy in the front line, your treatment options are going to be different. And if you've had BTK inhibitor or BCL2 inhibitor in the front line, then your therapy is going to be different. It also depends on where you live, how frequently you can come for follow-up, and more importantly, what kind of comorbidities you have. Things like hypertension, anticoagulation, heart arrhythmias or atrial fibrillation, atrial flutter, bleeding, bruising, being very important comorbidities to look at to make your decision. So, of course, there's still progress to be made. MRD remains an unexplored area or little explored area, and there is a lot to be done there. So if there are clinical trials enrolled, but if not, this is the general overview. So that's all I have. Thank you very much for listening, for your attention. Any questions, we'll take at the end.
Right. Thank you so much, sir, for such a wonderful performance, such a wonderful talk. Moving forward to the next talk, I would like to invite Dr. Abhijit Gunkude. He is a consultant in the Department of Hematology and Bone Marrow Transplant. Oncoprime Kolhapur Cancer Center, Kolhapur. He is going to speak on final analysis of phase 2 study with Daratumumab monotherapy in intermediate on high risk smoldering MM. Over to you, sir.
Can I share my share my screen, please?
Yes, sir.
Unable to screen. Okay, my screen is seen.
Yes, sir, it is visible.
Yeah. Am I audible? Am I audible?
Yes, sir, you are audible.
Okay. So I'll start my presentation. I'll be presenting the Centrus trial final analysis of phase 2 study in which Daratumumab was used as a monotherapy for intermediate and high-risk smoldering multiple myeloma. So as all of us know, smoldering myeloma is a symptomatic precursor to active multiple myeloma, and intervention at this stage could probably delay the progression to multiple myeloma. Currently, there are no approved treatment modalities to treat SMMM, though some experts recommend Len-Dex or just Len to especially the high-risk SMM group. Now, this trial, which is phase 2 trial, that is Centrios trial, evaluated the efficacy of Daratumumab monoclonal antibody, or it was just used as a monotherapy for delaying the transition to symptomatic multiple myeloma in patients who were intermediate or high risk SMM. So to determine the dosing strategy, the Equila study was reviewed, was assessed, and the dosing schedule was based on this Equila study, which was a phase 3 trial. And in primary analysis, Daratumumab was active and well tolerated in this study. So based on that, the dosing schedule was designed. The current report represents the final analysis of phase 2 Centrios study after median follow-up of almost 7 years, that is 85.2 months. So this was a randomized open-label phase 2 study, and total about 41 patients in each group was studied. They were untreated, intermediate risk or high risk SMM, and this risk stratification of SMM was done based on the marrow plasma cells. The plasma cells should be more than 10 and less than 60, and the serum M-band should be more than 3 grams per deciliter. Urine M protein should be more than 50, and the kappa lambda ratio should be between 8 and 100. Based on this, the risk stratification was done into intermediate, high risk, and low risk smoldering multiple myeloma. Now, there were the study patients were randomized into 3 groups. One was long intense, the second was intermediate, and the third was short intense. So in long intense group, the patients received weekly Daratumumab for 8 weeks. Similarly, in intermediate and short intense also, they received 8 weeks of weekly Daratumumab. In intermediate and long intense group, they further received Daratumumab, whereas in short intense, further Daratumumab was not given. In long intense group, next 2 to 3 weeks, they received weekly Daratumumab, and then once in a month, and later on once in 2 months. And in intermediate group of this trial, they received once in 2 weeks. Then extension was advised in certain group, but that was optional. The primary endpoint of this study was complete remission, progression of disease, or death, whereas secondary endpoint was overall response rate, PFS, and overall survival. So this was a baseline characteristic of all patients who were included in this study. The median age in all 3 groups were between 59 to 65 years of age. Females were constituting the predominant population in this group, of approximately 48 to 58% in each group. Then IgG multiple myeloma was predominant multiple myeloma type of multiple myeloma which was there, and the high risk FLC ratio was seen in approximately 5 patients of this total cohort. So these were the baseline characteristics and the response rate. As you can see, the overall response in long, intermediate, and short group were approximately 58%. Stringent CR was seen in about 15% of the patients, and complete response was just seen in about 2.4% of the patients. The median duration of follow-up in this study was 85.2 months. Range was between 0 to 94.3 months. You can see PFS in intermediate study group and short group was up 84 and 74 respectively, whereas the PFS was not reached in long arm. Overall survival was 81, 89, and 88 respectively in long, intermediate, and short group. And you can see the commonest adverse event was upper respiratory tract infection. Very few serious adverse events were noted in this group. As you can see, related to Daratumumab, only 3 events were there, and discontinuation was only seen in just 2 patients. So very minuscule side effects related to Daratumumab was noticed in these all 3 cohorts. The commonest side effect seen was hypertension. You can see in all these groups, this was the commonest side effect. Commonest serious side effect seen was pneumonia, and death related to or death within 30 days was seen in only 1 patient. You can see lot of secondary primary malignancies were noted in this cohort. Don't know the exact reason. There was CA breast, basal cell carcinoma, melanomas, lung cancers, prostatic cancers, also light chain deposition in kidneys. So to conclude, the final analysis of phase 2 Centrios study with a median follow-up of 7 years, Daratumumab as a monotherapy showed clinical activities in this group of patients, especially the intermediate and high-risk SMM, and trend towards longer PFS and time to the next therapy was seen. So definitely it had benefit. No special safety concerns were observed in this study. And of these, long, intense, and intermediate arm, 44% completed 20 cycles. So definitely the tolerability was not an issue. Investigators suggest that long, intense dosing schedule had longest PFS, time to the next treatment, and supports ongoing phase 3 Aquila trial. So only time will tell us whether after this is phase 2. So phase 3 study has to undergo on, and then we can actually comment on this whether Daratumumab will make a big difference in treatment of smoldering multiple myeloma. Thank you very much. Over to you, madam.
Thank you so much, sir, for such a wonderful talk. Now, moving ahead, we have. I would like to invite our next speaker, Dr. Shobra Neelbal. He is an assistant professor in the Department of Hematology, NRS Medical College and Hospital, Kolkata. He is going to speak on current and emerging roles of BTK inhibitors in treatment. Over to you, sir.
Hello, am I audible?
Yes, sir.
Yeah, thank you. Okay, please share my slide from your end. Huh? Yeah, thank you. So I need to put the video on, no? Yeah. Yeah. Good evening, everybody. Thanks for the kind introduction. So BTK inhibitors approvals and current status in mantle cell lymphoma. So here we see is that the currently what approval is there is with acalabrutinib and with zanubrutinib, and that has been approved by FDA, who have received more than one prior therapy, and there are phase 3 testing as part of combination regimen that I'm going to discuss, and there is a withdrawal for ibrutinib in the segment of the disease mantle cell lymphoma for in United States. Next slide. So first I will discuss the triangle study. That is, it was a randomized open label 3-arm phase 3 trial, and patient was previously untreated in the stage 2 to 4 mantle cell lymphoma. The patients were aged less than 65 years, so that they were suitable for high dose cytarabine and also autologous stem cell transplant. The performance scale was taken for 0 to 2, and total number of patients were 870. The primary endpoint was free survival, failure free survival. The primary endpoint was failure free survival. Secondary endpoints were response rates, PFS, overall survival, and safety. So the arm A of the study comprised of alternating R-CHOP and R-DAP into 3 cycles, followed by autologous stem cell transplantation, then clinical observation. Arm I consists of R-CHOP plus ibrutinib along with R-DAP 3 alternating cycles, and arm C consists of arm A, that is R-CHOP R-DAP plus ibrutinib along with autologous stem cell transplant and 2 years maintenance, followed by 2 years of ibrutinib maintenance and observation. So let's see the results. Next slide, please. So here we see that almost in the failure free survival, the median is not reached with the arm A, and with overall survival all the 3 curves meet together. Next slide, please. So what are the conclusions of the triangle study? The ibrutinib did not increase the R-CHOP RDAP toxicity. Ibrutinib did increase the serious infection risk after ASCT. That after ASCT, if we consider ibrutinib maintenance, then it is more toxic considering if after autologous transplant. So grade 3-5 infections and infestations are more if we give ibrutinib maintenance after autologous cell transplantation. So addition of ibrutinib during induction and food for 2 years as maintenance may allow for subtraction of autologous stem cell transplant in first remission. So if we add ibrutinib during induction with R-CHOP and for 2 years as maintenance, after that with ibrutinib, we may omit autologous stem cell transplant in first remission. And what I have shown is that ibrutinib and no ACT appears to be the winner at this time, best combination of efficacy and toxicity. Next slide, please. So this is a brief study which shows that janabrutinib based induction and maintenance in young fit patients with untreated mantle cell lymphoma. So previously was heavily pretreated, it was untreated, and it was with janabrutinib. It was a phase 2 study from China, and the preliminary and the primary endpoint was MRD negativity. Secondary endpoint was duration of MRD negativity, PFS, and overall survival. So here we have age group of 18 to 65, ANARBOS stage 2-4, Eastern Cooperative Oncology grade scale of performance status of 0 to 2, no CNS involvement or no prior stem cell transplant. So estimated total 47 patients were enrolled, but what the therapy is distributed in the form of R-CHOP into 3, alternating with R-DAP into 3 every 21 days, plus janabrutinib in cycle 135 with R-CHOP. So if a patient had more than partial response, then patient was subjected to ASCT conditioning, and optional ASCT investigation discussion was there, followed by maintenance with janabrutinib with 160 milligram BID continuously for 2 years. And regeneration of peripheral blood cell count after last cycle of induction, that is taken as ANC more than 1000 and platelet more than 50,000. Next slide, please. Next slide. So that already the distribution that has been a balanced distribution, but there is a male preponderance here. The median age was 52. Next slide, please. So what was the result? So median follow-up was for 35.7 weeks. That is approximately 36 weeks they followed out. 5 out of 7 patients completed the MRD test. All achieved MRD negative after 2 cycles of induction. All achieved MRD negativity in both peripheral blood and bone marrow. What was the efficacy? 4 out of 7 completed more than 1 efficacy evaluation after 6 cycle induction, and all achieved MRD negativity in both peripheral blood and bone marrow. only one patient received ASCT, all patients remained on treatment, that is zanubrutinib maintenance. So here we can omit autologous stem transplant. The heavily chemo exposure can be read, because all know that in autologous stem cell transplant we give high dose chemotherapy followed by stem cell rescue, which are of the patient's own patients. Next slide, please. So safety set, what was the safety that was noted with zanubrutinib in these 7 patients? So there were no death and there was no drug discontinuation. However, grade 3 neutropenia was seen in 2 patients, thrombocytopenia was 1 patient, and there was increase in AST, ALT level, and as such, no hemorrhage or cardiac side effects were noted. Next slide, please. Next slide, please. So another study is bendamustine rituximab BR, that is bendamustine rituximab plus cytarabine plus minus acalabrutinib versus BR plus acalabrutinib previously untreated older MCL. So it was a multi-center randomized open label phase 2 trial, and here bendamustine rituximab into 3 cycles followed by rituximab plus cytarabine into 3 cycles, again bendamustine rituximab into 3 cycles followed by rituximab cytarabine into 3 cycles. Then we give acalabrutinib. Acalabrutinib was added here, and the third arm was bendamustine plus rituximab plus acalabrutinib into 6 cycles. So therapy was continued until progressive disease or unacceptable toxicity. What was the primary outcome? Composite of CR rate by PET-CT and peripheral blood MRD negativity rate. Secondary outcome, we see PFS, overall response rate, overall survival, mobilization failure rate, safety. So this was again adults with previously untreated, that is the front line, but it is only phase 2 trial. Next slide, please. So this another study is that Acurili 1804. This is a modified VR cap plus acalabrutinib for transplant eligible patients with MCL. So this is again previously untreated patients with MCL 18 to 75 years. And here we see that that cycle 135, each cycle is of 21-day duration. Here VR cap plus acalabrutinib for up to 6 cycles until progressive disease or unacceptable toxicity. And cycle 246, that is 21-day cycle, that is acalabrutinib parallelly BID for 21 days followed by rituximab plus minus human hyaluronidase. I have no experience of rituximab with hyaluronidase administration, and cytarabine on day 1 and 2. This protocol is bit toxic. However, I see that this is quite dose intensive and drug dense protocol, chemo protocol. Next slide, please. This is the SHINE study, which shows that first line ibrutinib plus bendamustine rituximab followed by rituximab maintenance in older patients with MCL. This is we almost always practice. Generally, it's a multi-center. It was again phase 3 trial. So here again, patients less than 65 with previously untreated, that is the newly diagnosed. This can be quite applicable for our practice. Here BR induction followed by 6 cycles. So if the patient achieves CR or PR, we give R maintenance. Generally after BR in many of the studies or protocols, we don't give R maintenance, but here they have considered for R maintenance in one arm or ibrutinib 560 milligram OD until progressive disease or unacceptable toxicity. Another is BR induction for 6 cycles, if R maintenance for 12 cycles, placebo until. So here both in the maintenance part, there are both rituximab maintenance along with ibrutinib 560 OG after BR 6 cycles. So investigator assess what is the primary endpoint, that is the investigator assessed primary progression-free survival. And key secondary points are overall responses, time to next treatment, overall safety, overall survival and safety. So see the result, please. Next slide, please. Next slide. So these are the study is quite balanced both in the ibrutinib arm, which is used in the maintenance, and in the placebo where there is no the placebo. You see the median age is almost similar. Male is almost similar. Almost all the points, that is bone marrow involvement, blastoid morphology, extranodal involvement, bulky disease, which is more than 5 centimeter, T50 mutated and T50 mutation status unknown, is almost similar in both the arms. Next slide, please. Next slide. So what we see is that the median follow-up was for 7.1 years. That is quite great, I would say, considering the age, that is the 64, and the median age was 71 years. And what we see that there is 2.3 years statistically significant and clinical meaningful improvement in the median progression-free survival observed in the ibrutinib arm compared to placebo arm. So here we see that if we give ibrutinib along with rituximab maintenance after bendamustine rituximab as induction for 6 months, so here we get a 2.3 year statistically significant survival advantage, and it is seen in both, you will see in both the blastoid morphology, that is the aggressive variant of mantle cell and patient with T53 mutation. Next slide please. So if by subgroups also this ibrutinib maintenance after the BR is better if all the this forest plot shows that if we consider the male female, the white race, non-white race, age also, it shows that it favors the bendamustine for rituximab combination followed by ibrutinib maintenance for until the disease progression across all the study points. Next slide please. So fewer patients in ibrutinib went to receive second line therapy. That is because the CR rate was 65%. So definitely even the partial response is more in the ibrutinib plus BR arm. So an overall response rate, if we see in both the arms, is comparable. So definitely fewer relapses, so fewer need for second line therapy. Next slide, please. So what are the key endpoints? So death due to progressive disease or TAEs or treatment initiated adverse events were also less in the ibrutinib plus B arm. However, due to COVID-19 related deaths in 3 patients in the ibrutinib arm happened. But this study also, next slide please. The important thing is that in this study that they have not taken, which that is I have seen as a shortcoming, is that how many patients in this elderly age group has succumbed to any untoward cardiac arrhythmias, like because ibrutinib is quite notorious for cardiac arrhythmias and hazardous internal bleeding. So in the ibrutinib arm, 19.9% of patients receive subsequent therapy. And what we see in the placebo one, 40.5 patients have to receive subsequent therapy. The relapse rate has moved. Next slide, please. So again, the side effects, it is comparable in both the groups. As per the we can see the neutropenia, diarrhea is more or less same in both the arms. Next slide, please. So it is also this in treatment with BTK inhibitors typically is not treatment limiting, and secondary primary malignancy was also not increased in the ibrutinib arm compared to the placebo arm. So and also secondary AML was seen in 2 patients in the ibrutinib arm and in 3 patients in the placebo plus BR arm, and that is the secondary AML is most likely due to not due to ibrutinib, maybe due to the bendamustine agent. Next slide, please. Next slide. So another study, the ECO study, that is BR with or without acalabrutinib for untreated CML. So that was with ibrutinib, and here it is frontline. We will use acalabrutinib plus bendamustine plus rituximab in one arm. That is followed by rituximab maintenance plus acalabrutinib until progressive disease. And here that with placebo plus bendamustine plus rituximab followed by rituximab maintenance every 8 weekly for 1 year. So again, this is a phase 3 trial, and patients are less than 65 years and with requiring treatment, no prior therapy. That is frontline we can give now. So primary endpoint was progression-free survival. Secondary endpoint was progression-free by as per investigator. Overall response rate also by investigator, IRC, and overall survival. Next slide, please. So this is mangrove study, bendamustine rituximab versus zanubrutinib plus rituximab for untreated MCL. It is a multi-center randomized open label phase 3 trial. So here what we see, patients are aged less than 60 years and more than 60 years but less than 70 years with comorbidities. That is very common in India. With precluding ASCT. ASCT cannot be done. Histologically confirmed MCL, no prior systemic therapy with historic performance scale of less than 2. So zanubrutinib plus rituximab plus bendamustine plus rituximab, and then zanubrutinib monotherapy Primary endpoint was again progression-free survival, and secondary endpoint as per the last study. Next slide, please. But the results are not yet displayed. So another is acalabrutinib when was added to the lane R in untreated MCL, the response, and we see that that progression-free survival after median follow-up period was 86.7%, and median follow-up for 23 months, the 2-year overall survival was 100%. So the most patients achieve MRDCR with most response ongoing at time of analysis. So this is where acalabrutinib is combined with LANR in untreated MCL, and 2-year response rate and PFS overall survival rate good, I would say. Next slide, please. So this is a phase 1B trial, quite at its early stage. Acalabrutinib plus venetoclax and rituximab in patients with untreated MCL, 2 years efficacy and safety results. So here actually with or without censoring due to COVID-19, here we see that adverse effect in both the arms with venetoclax, acalabrutinib and rituximab in patients with the 2-year efficacy safety results are almost similar, with infections a little more in the acalabrutinib plus venetoclax arm, and that is due to neutropenia. Major hemorrhage is one of the limitation that I see in 7 patients, but no major hemorrhage, sorry. Cardiac events were seen in 4 patients, but there was no arterial fibrillation, and the side effects are comparable. Next slide, please. So these are the different trials that have been discussed. So Alliance trial is there, that is the phase 3 trial, untreated stage 1 to 4 mantle cell lymphoma more than 6, continuous versus intermittent maintenance therapy with zanubrutinib after CR with rituximab. So that is not yet recruiting this study, and primary endpoints is this. So these are different study arms. So I am not part of any of this. My center is not a part of any of these trial arms. So okay, next slide. So what are the summaries and key takeaways? So what is the role of BTK inhibitors in transplant eligible patients? So I have already told that if we add ibrutinib in the setting of autologous stem cell transplant, the toxicity is more. So better we should omit ibrutinib in the induction, or if we plan to give ibrutinib maintenance followed by ASCT. So ibrutinib should be avoided if we go for autologous stem cell transplant. Can we improve on BR in the first line setting without transplant? Yes, the trial showed, the SHINE trial showed. Yes, we can add acalabrutinib to BR. Also, we can add ibrutinib to the BR in the first line setting without transplant. We can followed by acalabrutinib maintenance. Can we reduce the use of chemotherapy as initial therapy for patients? Importance of the simpatico trial. Still, there are early data. Is only the venetoclax and acalabrutinib can be added, but it is still in the phase 1B study. So I cannot miss the trials that do not at present support for reduce the use of chemotherapy. Choice between bendamustine, rituximab plus zanubrutinib, another interesting study. So you were considering zanubrutinib and rituximab and bendamustine. I would prefer rituximab plus zanubrutinib, but those zanubrutinib is not available in my country right now. It may come in subsequent another 1 or 2 years, but right now we have to stick with bendamustine, rituximab, and we may add another BTK inhibitor. Should we use BTK inhibitor in the first line or safe for second line? As per all the trial study and trial report, it is shown that BTK inhibitors is used in the front line. There is no side effect profile. There is no increase in the there is no difference in the patient outcome when we compare it to the standard of care therapy at present. So it should be added to the frontline therapy, provided the patient does not have to face additional financial burden due to addition of BTK inhibitors. And what is the optimal approach to use of BTK inhibitors for transplant eligible patient with mantle cell lymphoma? That I have already discussed, that ibrutinib should be omitted if autologous transplant is planned. Thank you.
Thank you so much, sir, for such an informative talk. Now, moving forward to our panel discussion, I would like to invite our moderator, Dr. Nitin Sood, and our panelists, Dr. Ulfat Aravani. She is an assistant professor in the Department of Medical Oncology, SKIMS, Srinagar. Dr. Shraddha Thakkar, she is a consultant in the Department of Medical Oncology, Vignaharta Polyclinic, Thane. and Dr. Sridhar Gopal. He is a consultant in the Department of Medical Oncology and Bone Marrow Transplant, Shri Krishna Hospital, Coimbatore, and Dr. Ankur Mittal. He is a consultant of Department of Medical Oncology and Bone Marrow Transplant, Oswar Hospital, Ludhiana. Over to you, sir.
Thank you very much. I'm just confirming if everybody is here. I don't have any slides. This was just supposed to be questions from the presentation. So I'll just put a brief slide. Right. So do we have any questions from the audience about the talks that we've had so far?
No, sir, we don't have any questions.
Okay. Well, in that case, we'll just start with the sickle cell anemia talk that we have. My question really is, I mean, since there are no audience question, if I just start with how do you treat and do you offer transplant to your sickle cell patients? Dr. Ulfat, can we start with you?
Yes, sir. So actually, we are treating same way as sir has actually said in his presentation, that in India we have only one strength available, that is 500 milligram. But usually the conventional dose, what mostly we use is 25 to 50 in a pediatric population as per the body weight. But it is the fixed dose as of now. Transplant, yes, sir, we are not offering to most of the patients in our setting. Most of the patients go on treatment on hydroxyurea.
Yeah. I mean, I've seen during my travels to the central part of India where it is predominantly there, that a lot of people are not even taking hydroxyurea.
Yes. Yes, sir. Actually,
I don't know why that is, but that's the reality at the moment.
yes.
So, Dr. Shraddha, what is your view on the sickle cell talk?
Then definitely hydroxyurea is required, and I agree to your point. Even educated families in Mumbai refuse to take any medicines for sickle cell, saying that they don't have any symptom, nothing is happening, why to take?
Yeah. Okay. Dr. Gopal, we also noticed that the Indian sicklers are different. I mean, we've known this for a very long time. Do you feel the same? I don't know
Yes,
if
sir.
Dr.
Sorry,
Gopal
sir.
is there.
Actually, I was a bit late for the talk, so I don't know what was discussed in the topic actually. Uh, Sorry for that. Uh, so can I repeat the question once again, sir?
Yeah, no, so my question really was that Indian sicklers land up in less problems than the African
Yes, sir.
ones.
Yes, sir.
And I don't know, initially there used to be this school of thought whether they have this high HPS or high HPF level, which protects them
Yes.
against crises. I don't know if that's your experience as well.
Yes, sir. Basically, the sickling crisis in our setup, yes, for Indian sickles are slightly on the lesser side than compared to the African sickles. So that's why most of our patients, they're kind of reluctant to, even as per the discussion, even to go on with hydroxyurea. And many patients, even we say or push up a transplant. One thing is that, first of all, they are not agreeing that they want to undergo a transplant. Many times they are reluctant because I'm almost comfortable with this. Why we need to go for transplant? Unless they land up in a recurrent sickle cell crisis, they are not coming with any assuring thing like transplant is the only option. So for most of our patients, even for financial backgrounds, so we are just pushing on with hydroxyurea. We are not into the transplant in our setup also.
Yeah, sir, Dr. Ved, you wanted to say something?
Yeah. So Nitin, just out of curiosity, that though I'm not, treating sicklers or anything, but you guys are the experts out there. There are drugs, and there is an orphan drug status and an FDA approval to something called as Niprisan, and Niprisan was shown to, and this approval is more than a decade old, and Niprisan was shown to reduce the sickling by a substantial amount, and this is a plant derivative. So, are there any other strategies apart from hydroxyurea?
I've never personally used them, but Gardner's channel blockers used to be drugs which would prevent red cell dehydration. I don't know. Dr. Pendekar must be a better person to answer that question. I
Dr.
won't call
Pendekar,
myself.
are you there? I think he's
He's probably left.
yes.
But I think these drugs are not available in the country, so I don't know if anybody has experience with them.
रमन मैं मीटिंग છે फिर कर दूं
So moving on,
Sir,
the
one thing,
next talk.
sir, is there any so one thing, sir, out of curiosity, I'm asking,
Yeah.
is there any crisanlizumab available, sir, for this pain crisis? The selective P blocker.
Yeah, no, not
Is
that
that
I know
available
of.
in this?
Not that I know of. I mean, we get very few sicklers, so it's only usually when you go to Ranchi OPT or some other place in central India that you see sicklers, but otherwise, very few sicklers in Gurgaon at least.
Oh, so here we are in the almost southern part of Tamil Nadu. So basically, it's like even the sickles are very minimal here.
Yeah.
There are some good belt in at Ooty, if you are aware, Ooty Kunnur range.
Yeah.
So we do get some patients from that zone. So again, after of them, the prices are slightly on the lower side. So they tend to do well with the hydroxyurea.
Yeah.
Yes.
Okay. So moving on, the all oral AAA regimen for APML. What do you think? Is that feasible? Is that practice changing? Will that, Dr. Ankur, if you can take that one? I mean, I don't know if you heard the talk,
Yeah,
but it
sir.
looks like quite an attractive option.
Yeah, sir. It's a quite attractive option because in APML patients, like 45 days or 60 days of ATO injections, the patient has to travel down to the hospital daily.
Yeah.
Like, and after initial 15 days of induction, 15 to 20 days, when the patient is stabilized with the blood products and the transfusions independent. So oral, it means then the patient has OPD-based treatment. It's amazing, sir. I think it is a acceptable option in the Indian scenario in the coming times. I don't know, is it really available arsenic trioxide in India yet as oral? I don't think so.
No, I don't think, not that I know of, but if it was, would you consider changing it based on the data so far?
Yes, sir. As the in the talk, it has been mentioned that the bioavailability is equivalent. So during the initial phase only, we face the problems for the differentiation and all in high risk patients or intermediate risk patients. Once the patient is transfusion independent, we can call them like every once in a week for the routine checkups, like the counts and all, and they can take the medicines at home. I'm little bit regarding the cardiac issues like the QTC prolongation and all those will how to if in case the patient has any issues with that or not, because it was not mentioned during that.
No, I know. I'm sure it's going to be the same as IV arsenic, but that would lead us to avoid sort of peripheral opaque lines, and
Yeah.
at least a lot of cost would go down because of that. So, Dr. Ulfat, what do you feel about that data? About the AAA data?
Yes, sir. It seems very interesting, especially for underdeveloped countries. I think so because the patient compliance as far as IV later on, especially, is not that good because I've seen most of the patients, they don't feel comfortable with IV. It seems to be, but my query is about is it efficacious in high risk?
Well, from what I've seen, it seems to do equally well with the chemotherapy arm. They've risk stratified based on the white count and the age. So it looks like both groups are doing equally well, but obviously the data needs to mature for us to give any
That part
formal.
it was shown that is given with chemo, but slightly I'm concerned for high risk. I mean, I think for low risk because bioavailability and other things.
Yeah, no. So that's what I'm saying. I mean, at the moment, the data needs to mature, but at the moment, they're both equally doing well.
Okay.
But I did notice the risk stratification was slightly different to what risk stratification we do in the clinic at the moment. So moving on, the next talk was on the relapsed refractory CLL. So that was my talk. So Dr. Shraddha, do you have any views on how do you treat? So let's say CLLs who relapsed after BTK inhibitors. Do you use venetoclax at the moment? You went on mute.
Sir, yes, I have used it for 2 of my patients and they have so far responded well.
And I'm just interested to know, do you risk stratify? Because at the moment it seems a bit pointless. But do you still risk stratify?
Yes, sir, we
Sort of
definitely.
at relapse. No, I don't mean at diagnosis. I mean at relapse.
At relapse, it gets difficult, sir, to stratify actually.
Yeah, because I mean, plus it doesn't seem very practical to do at the moment.
Yeah, exactly.
Yeah. Okay, so let's move on to the next one, the
Sir,
smoldering myeloma talk.
sir, I have a question.
Yeah.
During the relapse refractory CLL, if we get the cytogenetics done, will that change our treatment? Means, are you like?
Yeah, that's what I said. It at the moment it seems a bit pointless. I think at the moment MRD assessment is better. Our MRD at the moment is flow based and pretty sensitive. So I'm sure most centers have 8-color, 10-color flows now, so you can do MRD analysis at a depth of 10 to the power -5.
Peripheral
-4
blood?
is enough for CLL though. MRD analysis would at least point out whether you can do fixed dose therapy versus continuous therapy, plus can sort of help you prognosticate a patient. And if you saw the Murano data, it'll the the Ven1, Ven2 data. If you look at that, then the authors recommend you should have at least 12 months of venetoclax before you can retreat. So it gives you a better treatment-free window and a better overall response rate if you are to use venetoclax again, because beyond that we still don't have idelalisib and duvelisib, and plus there is a big question marks to their safety. So if you can prolong the remission duration, then it's probably better. So MRD is a good endpoint.
Sir, MRD you are doing on peripheral blood?
Yeah, I don't think it matters at the moment.
Yeah.
You can do it on peripheral blood, bone marrow. You get 1 log difference. So as long as you interpret it accordingly, it probably doesn't matter.
Right, sir.
Sir, I have a query, sir. If at all we are starting giving venetoclax in the relapsed refractory CLL, so what dose are we are usually we tend to give, sir, for your patients? You start with 100 mg and when you'll go for 200 mg, because most of our patients are not tolerating now. So if at all you are giving venetoclax, what dose? Yes, you're starting, sir. How we are upgrading the dose?
Yeah, I think there's a starter pack for CLL. CLL you have to be very careful because venetoclax is a very, very effective drug.
Yes.
And so you have to literally start with 10% of the top dose, like 20 milligrams. The starter pack has like 20 milligrams for 3 days and then 40 for 3 days and stuff like that. That's not available to us. So we have to be very careful on debulking and tumor lysis prophylaxis protocols. So, which is why I think it's very important to debulk, for at least for us, to give steroids or fludarabine or whatever, however we debulk or treat early. But if you have the starter pack, then it's best to use that.
No, because yes, sir, I can understand. But what dose are we giving practically, sir? By any because I don't have any practical experience. So any of the speakers who have given venetoclax in such scenario, what dose have they given, sir?
Oh, you mean the top dose?
No, sir. Even for the basic dose, like what dose they have started and how far, how is it going on? Because
I don't
have any
start
practical
with
experience of this.
you start with a very low dose of 10-20 milligrams. 10 milligrams actually ideally. Problem is the
But
starter
we
pack.
don't have that low dose in India, no, sir.
That's what I'm saying. That's what I'm trying to tell you. The starter pack is only available with the original drug, which is very expensive.
Okay,
the generics don't have a starter pack because they're really built for AML based treatment.
Yes, sir.
So, which is why we have to be very careful of how we debulk our CLLs before we use the drug on our CLLs. So essentially, we're using, even if we do have to use venetoclax for our CLL patients, we debulk them first. We get them to a very low disease status before we can use, because literally we can only use 100 milligrams at the moment.
Yes.
Plus, make sure you don't have azoles on board and, it's not potentiated in any other way.
Sir, I have one query that venetoclax is a proven drug for relapsed refractory CLL. What if the patient has prior, taken BTK and we'll change the BTK in a relapsed? How is your experience?
So I didn't completely get the question. You're saying
I mean,
the
you have
patient has
initially given the
already taken
BTK inhibitors, yes, and the patient relapses and changing the drug. I mean, BTK inhibitors.
Yeah, so you're saying relapse, but I'm just
Yeah.
going to tweak that a bit. If they're intolerant to BTK inhibitors, you can use another BTK
Yeah.
inhibitor. Say if you have sort of uncontrolled hypertension, then you can't use zanubrutinib because that equally gives you hypertension. You have to use acalabrutinib. So say if they've relapsed on a BTK inhibitor, then venetoclax is a reasonable option. Either in a fixed dose combination of Ven R, which is 2 years, or Ven O, which is 1 year,
Yes, sir.
or Ven, which is ongoing.
Yes, but there is no option of giving, BTK again in combination or something. No, not as of now.
No.
Well, there is the when BTK inhibitor combination. So when Acala combination trial, which is going on,
Yeah.
but at the moment, it's not for people who've had BTK inhibitors. It's
Yeah,
only
it is
for
yes, sir. It's for those which have not been exposed to BTK. Okay, sir.
yeah. So moving on, the smoldering myeloma talk, which looked at the Centaurus trial. So do you think that's practice changing? Can we start with you, Dr. Wilfan?
Sir, I don't think it
I mean,
is.
would you consider giving Dara to a smoldering myeloma at the moment? Let's say high risk smoldering myeloma?
No, sir, I won't.
No. Yeah. Okay. Okay. Reasonable. Dr. Shraddha?
No, sir, I don't think so.
Okay. Any differing views, or should we just call it evolving for now? Right. So that's all I have. Unless you have any other audience questions,
There
back
is
to
one
Dr.
in
Vaid.
one in the question answer section.
One in the chat box. What is the duration of induction of AA in RR APML? Does any smoldering myeloma needs treatment? Oh, there's several questions actually. So what is the duration of induction of AAA in RR? I think that the talk covered, right? Does any smoldering myeloma needs treatment? No, that was my question. I think all the panelists have said no. Why early treatment? Yeah, so I think that really is a question that all the patients would ask us. Of can we prevent the smoldering myeloma from going, or delay smoldering myeloma from going into an active myeloma? And that's what Centaurus was looking at. And I think the data still, I mean, they've looked at 7-year follow up, which is quite impressive. But I don't know. All the panelists still feel that it's too early to say, and there's no firm recommendation. So, question to me is fixed regimen versus continuous therapy. Yeah, all are reasonable options at the moment. It depends on what the patients feel and how they can access the drug. The venetoclax on its own, venetoclax is a great drug for CLL. It would give you MRD negativity very quickly. And we know from multiple data sources that, including Morano, that MRD negativity should be your aim. But if you want to not do the drug long term, like some people would not want to because of compensation issues or staying in big city issues, one of our patients was very keen on doing a fixed dose therapy. So when obinutuzumab for a year or when rituximab for 2 years is a reasonable option. Would you repeat CLL fish in relapse? So that's the last question. And I think I've already asked that question. But Dr. Ankur, do you have a different answer, or would you not do that?
Sir, if it has all means, as we have discussed, we are not going to change the therapy with the repeat fish.
At the moment, yeah.
So we will
I
not.
mean, the NCCN recommends pretty similar therapies for 17Ps. If you had to prognosticate, probably you could do it.
And so more of if the 17P is positive, we are going to start with the BTKs, and most of our patients now we are giving the oral drugs at the start only. So even if they do relapse, they are already exposed to BTKs, means getting repeat.
Yeah, yeah. The other thing here is the mutation status. If you have a mutation which is, and at the moment it's not done, I should also mention that. If you have a mutation which makes it resistant to BCL2 inhibitor or BTK inhibitor, and then you would choose an alternate drug.
Yeah.
So that probably is a relevant thing. I think those are all the questions in the chat box, sir. So back to you, sir.
Thank you, Dr. Nitin, for that wonderful moderation. And I think everybody learned out of the exercise. And and my sincere thanks to all the faculty who delivered these lectures and covered the topics so very well. And the messages were very clear. And also to the panelists for the very enthusiastic discussions. And the participants who took time, enriched the program, and I hope everybody's enjoyed the proceedings, and there has been an enrichment of the knowledge base. And also my thanks, as I said in the beginning, to Mr. Om Mishra for the support, and Samarth Life Sciences, that's his organization, for the continuing support, to Rajesh, Mice Ideas, Priyanshi, and Anshika, and everyone who joined this evening. Thank you very much. We are well in time, 8:30 on the dot, and hope to see you soon. Have a very happy new year. Stay safe. Take care. See you in the new year with another topic. Thank you so much.
Thank you so much. Happy New Year.
Good night.
Thank you, sir. Happy New Year. Yeah.
Thank you, sir.